else do we have on the phone?
John Appler here, Rick. I'm at the post office with my wife, so I'm listening in.
Okay. Are you home?
John.
Are you back in
I'm home and
Are you back in Maui?
no, still here in San Francisco, but doing pretty well after my session yesterday.
Oh, good. Okay, we'll talk to you about that for sure.
Okay, thanks, Rick.
And somebody, and then,
Whoever that was on the phone, they dropped off.
yeah, they dropped off. I saw that. I saw that. Okay. So we have. Oh, so one is John and one is Diane. So John's, yeah, okay, we'll figure that out.
Oh, I don't see anybody else.
I don't either. Well, okay. All right, so let me write this down and then we'll get started.
Okay.
So, oh, and Larry Fish just joined us.
Yep.
Okay, so Jake, RD, Len, Dennis, Bill Whittemore, Peter, Jim Harrington, Larry Fish, John Appler, Larry, John Frost, and Paul Frieda. Okay, so I'll call this out, and then if we've missed anybody, you'll let us know, but I think we've got everybody. There's Jake, there's Len, there's Dennis Correa, Bill Whittemore, Peter Kafka, Jim Harrington, Larry Fish, John and Diane Appler, and Paul Frieda. Did we get everybody?
I'm Sylvester Mann.
Oh, Sylvester's here too.
Uh-oh. I made a boo-boo.
Oh, you made a boo-boo. Okay.
I've got two John Applers here.
Yes. All right. Do we know which is the real John Appler?
This one.
This one.
Okay. Sylvester, speak up one more time, please.
Hello. Hi, everybody.
Okay, got it.
Got it?
Yep.
Okay.
Hey, Sylvester.
Okay. All right. So we don't have anyone new. We have a couple of voices we haven't heard from in a while, or at least one. So let me just go down the list and see who would like to have some time today, and then we'll go from there. So Jake, how about you? Anything to report?
No, I have a doctor's appointment on Thursday.
Okay. Do we need to prep you? Do we need to do any prep work for the doctor's appointment?
No, I'm going to ask about a D3 test.
Good.
I did order some vitamin D anyway, but I'm going to ask her to do the test and see what she says. You know, yeah. I did some research. I did some research, and you know, calcium is low with Zometa anyway. But I will ask her about it.
Okay. Len, are you with us?
Yes, I am, believe it or not. And I'm actually on GoToMeeting.
All right.
All right.
How did that miracle occur?
Well, I have a feeling that our little GoToMeeting session this morning drained the battery in my wireless headset, so I just plugged it in to the power source, and now it works. Okay.
All right. Amazing what happens when you have power to all of your equipment. Okay. Len, is there anything you would like to discuss tonight?
No, sir. Nothing. Thank you.
Okay. Dennis Correa, how are you doing, and is there anything you would like to talk about tonight?
No, not really, but I do have to leave after about 45 minutes or so.
Okay. Okay, well, we welcome you for as long as we've got you.
Thank you.
Might I add, it would have been a lovely day to play golf in Tubac today.
I played yesterday. Did well.
In Tubac?
No, just locally up here. We had our annual memorial tournament for our club.
Okay. Okay. Bill Whittemore, how about you giving us a little update on how you're doing?
Sure, will do, Rick. So I have been.
Hold on. I'll come back to you. I'm just planning. Sorry, I'm just planning who needs to speak, but we'll come to you. You'll be first up. Peter Kafka, anything for you?
Yes, I've got something.
Good. Okay. Jim Harrington, how about you?
No, not tonight, Rick. Just becoming an expert on chemo, so I'm just coasting along. Yeah, it's a lot of fun.
How many?
I think I've had about 10. And I don't know how many more. I'll just keep having them.
Well, I'll try and remember, there was a I know you're not on carboplatin yet, but there was a really interesting piece of research that was at last Wednesday about carboplatin. So maybe.
Oh, good. Are you going to give a review of the meeting
well,
to start off?
I can't review. There were 74 abstracts, I think, and 12 papers. So I've given everybody a link, and
okay.
And it was in the letter that I sent around, and I'll post the link in a minute in the chat window again. And you can.
Okay, I'll go read that one. Yeah, that would be very interesting about carboplatin.
I've got my list here, and I will tell you what the number is, and then you can. Well, I'll tell you ahead of time, and then if you want to talk about it, it was abstract number 6.
6. Okay, thanks, Rick. I'll look it up.
Okay, and I'll put that as soon as I get done going through everybody. I'll put the link in the window again.
I've also posted it on our Facebook page, the link that you gave us.
The link that I gave you?
Yeah. To all the abstracts.
Yeah, could you post it in the chat window for me, Jake?
Yep.
Thanks a million. Okay.
Give me a minute.
Larry Fish, anything for you today?
Hold on. Am I talking? Yeah.
Yes.
Nothing special. I just want to say that advancing prostate cancer lecture on the 6th of November was really a very good overview, and the Q&A was really valuable too. So if anybody didn't listen to that hour and a half, the one that's posted by us too,
right?
I would recommend that as a very good. It helps firm up everything we know.
Okay, great. Now that was not the one with the medical oncologist about chemo. That was the second one, correct?
Right. It was not the chemo one, which I listened to, which annoyed me actually.
It annoyed me too. So I agree with you. Rob thought it was really good and thought I should post it, and so I did. But I posted it with reservation. But I will try and listen to that second one. I think I posted it, but I haven't had a chance to listen to it. But thanks for telling us. Maybe
it's great. It'll firm up everything we know and we've been talking about, and it had some little clarifications and extensions of things that we talk about. But basically, we're right on target here at this group.
Who was delivering it?
Oh, I don't know, Dr. Morales, Dr. Gun Uganti, and Dr. Michael Leiss. Mm-hmm. I didn't really write their bios down, but they're in the field.
Okay. John, would you like to tell us a little bit about your experience yesterday when we get to you?
Yeah, sure. I got to help my wife, but if I'm not on mute, I'll jump on. I'll be happy to, Rick. Thanks.
Okay. Paul Frieda, anything for you?
Yeah, just a short question or two.
Excellent. Sylvester, anything for you?
No, not this evening. Thanks very much.
Okay. So I think I've covered everybody. And Jake has been good enough to post that link in the window to all the abstracts. So if I refer to any of the abstracts today, you're all going to be in a position to actually look at the number that I'll give you. So Bill Whittemore, let's kick off with you. Tell us how you're doing, what's news, etc., etc.
All right, thank you, everybody. Coming off the last time I was on with you all, I had completed about 15 infusions of chemo, docetaxel, in the spring, and then learned in the summer that I couldn't resume chemo in any form because I have myelodysplasia syndrome, where my bone marrow doesn't make enough mature blood cells to make me eligible. And so on the call the last time, Rick, you were good enough to suggest a couple of names at Yale and at Memorial Sloan Kettering, and I went to see Daniel Petrolak at Yale.
Mm-hmm.
And he really confirmed that there aren't a lot of options for me that are in terms of any conventional treatments, but he recommended that I retry Zytiga.
Mm-hmm.
And I'm starting on Zytiga today.
Okay.
And the hope is that that it'll have a good effect. We'll just have to see.
Did you talk to anybody? Well, let me just step back one. When did you see Petrolak in October?
Yes.
Okay.
October 19th, I believe.
Okay. And go ahead.
He as I recall, we discussed a wide range of things, and among them was genetic sequencing and
yep.
What that might lead to. And he said he'd like to see me try the Zytiga first, but that the problems with gene sequencing, and I'd love to know if anybody else knows anything about this, but he said that what we'd be looking for is mutations in your cancer cells that would then allow us to perhaps treat
correct
your cancer, but then you'd be looking at clinical trials, and you're not eligible for any clinical trials given your myelodysplasia syndrome, which takes you out of eligibility. And that was the advice I got at Memorial Sloan Kettering and at my local oncologist before them regarding clinical trials. But I didn't know where gene sequencing would lead until I talked to Dan about that.
Okay, we can definitely discuss this with you, but I would say that there's every reason to do gene sequencing because some of these drugs are available outside of clinical trials. I mean, I can think off the top of my head of half a dozen men who have accessed these drugs outside of clinical trials, some with and some without additional financial support. So the reason not to do a trial because you can't access a drug is bogus in my opinion. Or, as Click and Clack might say, bogus. So go ahead, Bill.
Yeah, no, and absent the other thing we discussed, briefly was that, and you mentioned the possibility of financial aid, but I mean, he said you're looking at very, very expensive program without Medicare coverage, and you know, could cost you gazillions.
Well, it could.
What do you think about that?
Well, what I think is let's cross that bridge when we come to it. The first thing
I
to
agree.
do is you don't have the information.
Yeah.
And without the information, you know, when we start talking about what ifs, to me that doesn't make sense. I mean, we've had this discussion with another guy on our call and with another, and not a medical oncologist at a center of excellence. And to be honest, I'm kind of surprised that a medical oncologist at a center of excellence is deferring genomic sequencing in given the state of knowledge that we have today, and a situation like yours where it's not really clear what the best treatment path would be for you. You know, the myelodysplasia that you're suffering may correct itself. I mean, the fact is you had 15 docetaxels. That's a lot. And it's not surprising that you got myelodysplasia after that. And it may be that that can correct itself. And I mean, I'm sure you're running monthly CBCs, complete blood counts.
Yes.
And,
yes,
you know, God willing, what we're going to see is a return in your platelets and in your hemoglobin and then everything else. I mean, I've got a note here that your hemoglobin was up around 11.7 not so long ago, which is pretty good.
Yeah, it has been pretty good. I was on Aranesp, which is a drug to take care of red blood cells when you have myelodysplasia, and it's been a while since I've needed a shot because my numbers have been good.
So, you know, for a GU med-onc to turn around and say, well, we're not going to sequence you because you're not eligible for any trials, to me is disheartening. Because,
well, let me be fair to that consultation, because what he was saying was try it, and that this may be no difference to you, but what he was saying is try the Zytiga first. Let's see how it goes for a few months, and then come back and let's discuss these other options. But these other options don't, you know, they're, you know, he wasn't. Let's put it this way: it wasn't an optimistic conversation.
Okay. Well,
but he did want me to try the Zytiga and then come back to him and see what the results are, and then we would look at the more exotic, shall we say? My word.
Have you been? I'm looking at my notes here. Have you been on Zytiga? Yes, you were. You were on Zytiga back in 2012, right?
No, 14 and 15.
Oh, 14 and 15. Okay.
Yeah.
Okay, so you have been on it. I've got a note here that you tried Zytiga and Xtandi.
Yes, the Xtandi following the Zytiga, as is typical with a number of patients, don't do well on the follow-on similar inhibitor. But you know, but the theory here is not studies. Apparently, studies don't bear this out, but there's enough anecdotal articles and so on that encourage retrying after chemo, retrying Zytiga.
Right. I understand that. Well, I think, and you know, we'll throw it open. But I think if it were me, I would be insisting on getting a sequencing. Do you have any easily identifiable bone mets?
Yes.
Whereabouts?
The lower spine, mid-spine, and clavicle.
Okay, so they don't like to biopsy the spine because it's too delicate.
Yeah.
But depending on where it is in the clavicle, you might want to discuss a bone biopsy there. I mean, there are guys who have done it. It's not a painful procedure, and it's pretty easy to do.
Yeah.
Failing that, you can send a liquid biopsy down, which seems to cover most of the actionable genes. It's not as comprehensive as a bone biopsy, but the thought is that if you send a liquid biopsy to somebody like Foundation Medicine or Guardant, it will cover most of the actionable mutations. I wouldn't send it to one of those that only tests for like 20 or 17 or 23 mutations. I'd send it to one of the bigger houses. I personally would recommend Foundation Medicine only because we work with them, and the quality of their stuff is good.
Yeah.
But I wouldn't wait, because let's just say you do have something that's actionable, then why not look at it? Why not start right now? Let's just say you had something that was in the pathway of a PARP inhibitor. You can get the insurance companies are covering PARP inhibitors right now, and we just don't know. So
yeah,
and the longer we wait, the less chance you have of getting any sort of durable remission out of these drugs.
Yeah. Well, I certainly will. I will look into that with him, and I won't wait to see how the Zytiga goes, and I will explore it with him.
Let me throw it open to anyone else. I mean, who else has considered this type of testing? And I'm looking at the call. I don't know if there's anybody on the call right now that's done it.
Rick, it's Jim Harrington. I'm having that testing done now by Foundation One.
Okay.
They're going through the sequencing, and I was just going to mention my spine is full of bone mets, top to bottom, but they did not biopsy the bone met. They biopsied a lymph node, so it wasn't a blood sample, but it was a lymph node, and actually it was in my neck, and they biopsied it, and as a result of the chemo, the lymph nodes have gone away. So whether there's any tumor there, I don't know. So I want to say that, but short of sticking a needle into my spine, which you're right, it didn't sound very good to me either. Yeah. They used the lymph node, and I'm still waiting for the results of Foundation One, but I'm hopeful, and I don't know why when I ask, they just say still sequencing.
Well,
seems like
Jim, was that covered by insurance?
So far, yes. When Rick and I were together at the PCRI, we talked to Foundation One, and they said, "Oh, it'll be covered," and so forth. So far, I've not had a bill, but I don't want to mislead you that they won't charge something. Someday they're going to want to charge somebody something once they get their baseline full of their DNA samples. But he seemed to shrug it off, saying, "No, it'll only be half price." But I still thought I was looking at a couple $1,000s. But so far, I've received no bill. So I guess so far, okay. But I'm not sure what's going to happen in the future. Rick thinks I won't pay a dime.
Yeah,
no, I don't. Hey, Rick. Thank you, Jim. Rick,
sure.
I just wanted to ask you on the myelodysplasia syndrome. You were saying that it may correct itself, and that's very encouraging to hear. And I've been asking that question myself, and their answer is we don't really ever see it correct itself. And I wondered if you've encountered members of this call or elsewhere where it has corrected itself.
Well, again, I'm not a doc. I can't give you medical advice, and I may be misinterpreting. But what I have seen is people that have poor blood counts during chemotherapy and other treatments. I've seen that correct.
Yeah.
Now, myelodysplasia, may be a different cause. I don't know. I don't know. I mean, I know what myelodysplasia is. It's a suppression, I believe, of the bone marrow.
Yeah.
And I think it's often caused by the cancer.
Yeah.
But and I have seen guys who have had that situation, and it has corrected itself over time. Or when I say corrected itself, I've seen their blood counts come back. So
Yeah.
I can't. You know, I
Well,
can't say more than that.
Just to comment on that, for the benefit of the group, I was told when I had my biopsy to determine if I had MDS, that, and once they diagnosed it, they said chances are that the combination of the external beam radiation I had way back after the radical prostatectomy and spot radiation that I've had, extensively since then, could contribute to the chance of getting it. But only about 20% of prostate cancer patients flirt with the possibility of myelodysplasia syndrome.
Okay.
So it's not common even when you have radiation.
Okay. Well, it could well be that that I'm confusing myelodysplasia with myelosuppression, and we don't have any. I don't know. Do we have anybody sufficiently medical on the call to help me out here? Guess not. So, my thought was that you may see some recovery, but I don't know. So,
well, there's a lot of logic in what you say, and indeed, I have recovered enough from a couple of months ago when my blood counts were so bad I was having trouble walking around.
Yeah.
Now they're very good, but what my onc says is, yeah, they're very good for you walking around, and that's great, and that's very possible, but you can still have MDS even when you're feeling good.
Right.
So that's.
Well, I'll do a little more research and see what I can find, but I still think that the genomic sequencing, if it points to an actionable gene, will be helpful, because just you don't have to be in a trial to get some of these drugs.
Yeah.
We're in a
thank you.
environment. Pleasure.
Thank you for that. I will pursue it. It is strange. My genitourinary oncologist I consulted at Memorial Sloan and at Yale basically weren't. I wish they were speaking to me as enthusiastically about these things as you are now. But I will go back to them.
Well, I don't want to give you false hope, but I do think that in this day and age, when a man has advanced prostate cancer, any doctor that refuses to provide genomic sequencing at the earliest possible opportunity is not doing his patient the right service. As far as money is concerned, we have a pretty good relationship with Foundation Medicine, so we may be of help. We always tell people that if we can help you, don't forget us. So you can give us 10% of whatever you save. But
right.
I wouldn't create money as the hurdle to overcome. I know that if money is the hurdle to overcome, we can work with David Marshak closely enough at Foundation Medicine to get you the sequencing. We won't let money come between you and your sequencing. Let me just go back to Jim Harrington a second. Jim, when was your Foundation Medicine test done?
Yeah, it was something seems funny, Rick, because it's been about a month and a half ago.
No, there's something.
And but about when I saw you when we were out together in Los Angeles, you know, it was a bit after that. And I need to see my doctor, Dr. Stein, and find out what's happened. When I asked the nurse, the oncology nurse, she just comes back with it's still sequencing, but it doesn't make sense. We should have the results, and I should get the results, and I'm going to ask again.
Well, you're right. Now, you know, I had a big issue with Jim Cameron over this, because he was getting bad information from his oncology group, and I feel it's the responsibility of the oncology group to pursue this. And if they haven't gotten tests back within 6 weeks, when the test should only take 2 weeks, there's something that isn't right. And
that's right. That's the situation.
You can defend your medical oncologist up and down, but it just won't wash with me personally. My recommendation to you is to call Foundation Medicine tomorrow.
Oh, okay. Oh, that's a thought. I didn't do that.
Yeah. And tell them, look, you know, this was sent in by my doctor 6 weeks ago, and I haven't heard anything. They're really pretty good down there. If you hit an obstacle, let me know, and I will clear the obstacle through my own contacts down there. But I don't want to call them if it's not necessary, because I think.
Okay, it's a good point, Rick. I have not done that. I'll do it.
If you go to the web to Foundation Medicine, there's a telephone number. You give them the details of when it was sent down there, but it shouldn't take more than 2 to 3 weeks. I mean, Jim, we just got a message yesterday. I mean, they finally got Jim's sample after well over a month because it got held up at Hopkins for no good reason. And he was supposed to have had his stem cell biopsy back this week, and they came back and said they need to do additional testing. It's going to be 1 more week, but they're really responsive and communicative. So you need to call them and chase it up, and if you hit a roadblock, we'll see what we can do for you.
Okay, thanks, Rick. No, that's great. I will press on them and try to find out. I'm very interested. I'll let you know.
Okay.
Thanks.
Would anybody else like to talk about any of the issues that Bill Whittemore raised?
Well, one of the things, Rick, is still Jim Harrington again, but and I'm still undergoing docetaxel, and while I may not have had quite as many, I've had quite a few of them. And my blood counts are all over the place, and you know I'm anemic, and my hemoglobin got down to 7.3, and that's hardly very good. No. And I've just had a number of transfusions, and it really works. I don't know if you've had transfusions, but I mean a lot of us do because the bone marrow is compromised. I can't make red blood cells and whatever, but my platelets and everything. But I just keep going and face it all. But I mean, I don't know what you're supposed to do about it. You know, when you're anemic, you get shortness of breath, you get a little more fatigue, but just give you blood. And as they said, I get 2 units a time, and I've had at least 6 or 7 transfusions, along with a bunch of guys. And they said you'll blossom like a flower. Well, I don't know if I blossom like a flower when the thing was over, but it is quite something. I mean, it's a way to absolutely solve anemia or get your red blood count up,
right?
Your hemoglobin,
right?
But it's a thought. I mean, I don't know, and I know I sit in the cancer ward here in New Jersey, and there's people getting transfusions. So I'd rather not have them, but it does work. And Neulasta brings up your white blood count. So if you have Neulasta, I don't know if you can do these things anymore since you can't have any more docetaxel, but it sort of helps. But otherwise, your blood count goes all over the map. That's quite true. All the cells, seems to me. That's about all I have for you. But transfusions can help, no question about it. And my blood comes from Washington, D.C., but I don't know if it's a Democrat or Republican. Although I asked.
What color is it?
Thank you, guys.
They'll tell you where it comes from. They won't tell you any more than that. But
what color is that blood?
Oh, it's red. Yeah, I'm just
then we
red
know
through and
through. You're okay. You know, you always you want some of that blue blood stuff.
That's right. Yeah, that's right. Yeah, it is. But it does make you feel better. It's no question about it. Give me blood, and it just takes 2 hours per unit, and it's just a lot of time sitting. But I sit in cancer wards a lot, so especially if I have the docetaxel, then I have 2 units of blood. It's about a 10 or 11 hour day. That's all right.
Bill.
Good luck.
Bill, is the syndrome you have, is it myelodysplastic syndrome or myelodysplasia?
I thought it was myelodysplasia, but didn't know there were 2 different MDSs.
So,
Rick, it's the same thing.
It is the same thing. Okay, so
Yeah.
myelodysplasia, myelodysplastic syndrome, I didn't realize this, so I definitely stand corrected. Is some sort of early, fairly benign blood cancer. So,
Yeah, that's right. It could lead to cancer if you have a high enough volume of
right.
But I'm told I have a very mild beginning stage, and that it's not worrisome at this time, and in terms of other aspects of my health.
Okay, so then in that case, that is a different situation to myelosuppression, which is where your existing cancer is preventing your bone marrow from working properly, or the chemotherapy is preventing the bone marrow from working properly. So that is a different situation, and if that is the case, I can see that that if you've been diagnosed with MDS, then it is possible that that you wouldn't be eligible for most trials, but what I would say is that even if you're not eligible for most trials, it certainly doesn't X you out of some of these precision drugs.
Yeah. Do you happen, Rick, to know the names of any of these drugs that are not in clinical trials but are actually out there, are able to be prescribed?
Well, there's Opdivo, which is nivolumab. There's Keytruda.
How do I spell Opdivo?
Opdivo.
Mm-hmm.
There's Keytruda.
Opdivo.
Keytruda. Keytruda, which is pembrolizumab. There are several PARP inhibitors like olaparib, or the commercial name is Lynparza, Lynparza. Rubraca, Rubraca, which is a more powerful PARP inhibitor, and there are others that are even more powerful, but they're not available yet. And and others too that I can't tell you off the top, but there are several of these drugs that are out there right now.
Okay, well, that's great to know those names. Thank you, and I appreciate your overall perspective, because I'll revisit some of this stuff, especially on the genetic testing.
Okay, great. Yeah, look at the Foundation Medicine website, and that'll give you some information too.
Rick,
Foundation Medicine?
Yeah, Foundation Medicine.
Foundation Medicine?
Yeah.
Thank you.
Rick, I'm looking at a Wikipedia article on myelodysplastic syndrome, and they say some of the drugs therapy may include lenalidomide, anti-thymocyte globulin, and azacitidine. So there are a number of drugs that can be used to treat it, in addition to blood transfusions, antibiotics, and medications to increase the making of blood cells.
Thanks.
It's basically, from what I can glean, and it's very complicated, this syndrome. It's not real simple that you can summarize, but basically it's a disease of the mature blood cells.
Mm-hmm. Right. That's exactly right. I'm not producing enough mature blood cells, and if you could have a bone marrow transplant, you might cure MDS, but then I would be back to taking conventional treatments, which might throw me, right back into MDS. And so that's where the hunt for something not in the path of the myelodysplasia, such as Zytiga, was viewed as a good idea. And then if there are drugs that can treat, say, a gene that's identified in the sequencing, then yeah, that would be good. But the cure, even if I cure myelodysplasia, I'm really not facing the extreme consequences of MDS. It's really a matter. I don't need treatment right now for that. I just need to, unless of course I could make it go away, and that's.
Well, this article does say that previous chemo or radiation therapy is a risk factor. So
yeah,
you stopping it, it's probably a very good idea.
Yeah, right.
Your doctor's probably on the right track with that.
Okay. So
yeah.
let's move on.
Thank you, everybody.
Pleasure. Peter.
Rick, you have two more people. Bill Burhan's joined, and we have a caller on the phone before you go on.
Ah, okay.
I think it might be Paul Frieda. He's been kind of dropping in and out, but I'm not sure.
Or John Appler.
Or John Appler.
Yeah.
It's John Appler, yep.
Okay, we got you, John, number 8.
I'm sorry I'm late.
Okay. So, Bill, how are you? Professor Bill, how are you doing?
Okay, I'm up in Vermont.
Oh, good. Say hello to Buzz. How's that wood stacking going?
Not enough of it. I think I need you to come back and help. But anyway, if you have a few extra minutes, I just want to update you guys on.
We will make time for you, Bill, for sure. Okay, Peter, you're up.
Okay, I had my monthly blood test yesterday. I already got the results. So the last 2 months I've been a little more than inching up. I've been going up 8/100ths last month and another 8/100ths this month. Last month it was enough to double my PSA. This month it wasn't. The 8/100ths wasn't enough to double it, but it's a steady climb. So I'm halfway to the trigger point for scans. I've got an appointment next month on the phone with Dr. Turner, and so I suspect I'll be ready to start scanning in after the first of the year, unless it starts jumping faster. And my question to guys is, what, I'm sure Dr. Turner will weigh in on this too, but what kind of scans would be appropriate? And of course, we'll talk about, post-scan, whether I go back on ADT and what form of ADT, and whether if it is metastatic to go to early chemo. There's all kinds of things. They're not on the table yet, but I'll bring them to the table next month. And I just want to get a feel of anybody. Len is in a similar situation, I guess, and what the appropriate scan would be. Should I let Dr. Turner arrange this? Should I go back up to radiology in San Francisco and talk to them about available scans? Should I go to pay out of my pocket and go to Dr. Almeida down in Phoenix? Kind of, just at the beginning exploratory stages in my head right now. All these things are kind of rattling around in my head a bit.
Why would you pay out of pocket if you went to Almeida, Peter?
Why would I?
Yeah.
Not only if his scan was some super scan that wasn't available someplace else. if that was made sense.
So
I don't know.
so
I mean, I know they have good scans in San Francisco.
okay. So I do have some information on this because I've been working with somebody in a similar situation, so I have a little bit of information. But let's go to Len first. Len, what are your thoughts?
Sorry, I had to unmute myself there. I think Peter and I have discussed this privately, and if I recall correctly, my recommendation was I'm a big fan of Axeman scans. They're FDA approved. I'm pretty sure that the insurance companies are reimbursing, and it's very sensitive. Maybe possibly one of the most sensitive scans out there. Certainly at the 0.2 PSA level, they are effective. Do you remember the conversation we had, Peter? I think that's what I had recommended. I know for myself, like you say, I'm in the same boat as you, and that's what my oncologist is recommending that we do when the time comes, which is probably quite soon, before the end of the year.
I'm sorry, Len, could you repeat what type of scan he's recommending?
Yeah, Bill, it's AXUMIN.
Oh yeah, okay. I wasn't listening. I'm sorry.
Right.
Okay.
It has several other names, which are difficult to pronounce.
Right.
Bill, what are your thoughts? Because I know you've been looking at something similar.
I'm in pretty much, or I was pretty much in the same boat until recently, but I've been receiving sodium fluoride 18 PET CT scans. I don't know how available they are at other institutions, and they're supposed to be 5 times as sensitive as a conventional technetium 99 scan, which is why I've demanded that I have them. But I'm beginning to learn that they're not widely used, and I don't hear much about them becoming perhaps the standard of care in the future. One of the problems with them is that they're so sensitive that it's difficult for anyone except an extremely well-trained radiologist to distinguish between, say, arthritic disease and a real metastatic lesion. But I think that the radiologists at our institution have done a pretty good job, because in many cases I've had both, and they correspond in several cases, not in many cases. So that that's what I'm planning to have them going forward, but only because that's the best test available at my institution. But I'm anxious to hear what other guys have to say, and I might consider something else too.
Right. So this has come up several times in terms of discussions I've had over the last 3 or 4 months. The best review of this, which I've already sent out to a couple of you fellas, is by Alan Edel, and it's a really excellent review. I'm going to post it in the chat window right now. I posted something else which I'll tell you about in the chat window. But let me just put Alan Edel's link in there, because I don't want to steal his thunder, and he's done a really great job here. So he reviews everything that's currently available. Hold on a minute, and here it comes. Okay. So that's the most recent link that's in there. What we know today is that, and there is debate about this, and I'll come to this in a moment. What we know today is that what we believe today is that the most sensitive scans are the PSMA scans. They pick up the prostate sensitive membrane antigen, which only occurs on prostate cells, although I shouldn't say only, occurs mostly on prostate cells. It does occur on some other cells, some in the esophagus, some around the thyroid, which for some reason or the other, having to do with, I guess, our birth, our development in fetus, have some prostate element in them. But by and large, they only show on prostate cells. And we believe that this technology is the best. Now, there are two different types of PSMA scans that I'm aware of. One is gallium-68, which is available in trial in a number of places, but you have to qualify for that trial. It's also available privately in places. I don't know what the situation is with insurance, but I do know somebody who got a PSMA, a gallium PSMA scan in Canada in the last month, within the last month. And that is probably the most effective private or non-trial scan that you could possibly get anywhere today. Secondly, that there is a better scan, and that's the link that I posted above Alan Edel, and that is with this F18, which is like what Professor Bill just got. It's with this F18 DCSF, I think it's called Pylinium, PYL. I forget what PYL stands for, but that is the agent. This F18 DCSF PYL. It's some type of F18, and they're running a study on that at UCSF. They're also running that study at other places. Peter Carroll is running that study. The only issue with that is you have to have a biopsiable metastasis to qualify for the trial, as best as I know right now. So it does remove a whole bunch of people who have recurrent disease, but they cannot see exactly where that disease is. It's kind of, I don't really get it, because it kind of defeats the object, because this is a great scan for people who want to know where their metastasis is, but they're not eligible unless they know they have metastasis. I don't really understand it, but maybe somebody like Peter can talk to Peter Carroll, since they have a relationship, and find out what the theory is on that, and whether there are any exceptions. But according to Alan Edel, and according to other, Alan is not a doctor, but I've talked to doctors about this too, that is the best and most sensitive scan that is out there, if you can access it, this F18 DCSF PYL. After PSMA, the next best thing is this Axumin scan, which is also uses some sort of F18 contrast. I forget exactly what it's called, but it's not a regular F18 scan like Bill has been getting. It's more advanced. And as recently as Wednesday, I heard Matt Cooperberg, Dr. Cooperberg at UCSF, recommending that scan to a patient who was asking him questions. I was waiting to talk to Matt, and he was telling this guy ahead of me, actually a guy who's been on our calls, but he didn't know who I was, about Axumin and recommending. Now, Axumin, according to the Axumin site, is available at UCSF. It's also available from Almeida in Phoenix. And the word is that Almeida, come December, come January or December or January, is also going to be offering the PSMA gallium-68 PSMA scan privately. I cannot tell you what the position of the U.S. insurance companies are, the stance with respect to covering, but supposedly he's going to be covering them. And one of the good things about Almeida is that he'll go fight the insurance companies for you. So if you could if that was a place to get a gallium scan, I would suggest it. I would also say beware of one thing, which is that anybody who's in the PCRI family, any docs that are in the PCRI family, push you towards Almeida, which isn't necessarily a bad thing because he's a very good doc. But I have recently heard one of the PCRI docs pushing Almeida over and above everybody else and telling the patient that, in his opinion, just a regular F18 that Almeida does is better than Aximin and is better than PSMA. Why? Because A, we don't have the experience reading Aximin studies. B, that the imaging isn't as clear as it could be. I mean, to me, this is all, in my opinion, personally, it's all BS, because I haven't heard anyone else other than this particular doc, who's a very well-known doc, slamming PSMA scans or slamming Aximin scans. I've only heard people have very good results out of those two scans. And to me, it just sounds like pushing business towards Almeida. And it kind of bothers me a little bit. And I've been working closely with this particular man who's getting some balance from me versus what he's hearing from this PCRI involved doctor. So I don't know, Peter. There's quite a lot of information there. If you can download and read out what Alan Edel says, you can bounce some ideas. I would be open to discussing it with your docs at UCSF as well as with Dr. Turner, and seeing what they say. If it were me and I could get a gallium-68 test and I could afford it, I think that's probably what I personally would do if I could find it available. And if I could not, I would go to an Aximin. And that's all based on the fact that I would not be eligible for this F18 PYL study that's going on in a bunch of places around the country. And I hope you're not eligible, because if you were eligible, it would mean that they would, I think the requirement is that you have to have something biopsyable within 6 weeks.
Right. Okay, well, that's good information. I'll start doing the research. As I said, I think I still have a couple months before my numbers going to come up on this one, but we'll see what happens.
Okay.
But I do have a telephone appointment next early in December, and we'll talk it through too.
Okay. And by all means, drop Peter a line. Carol, drop Peter Carroll a line and ask him, because he's the PI on this F18 DCF 18F, I should say 18F DCSF PYL study.
Okay.
Okay. The clinical trial. I don't know. I can't remember if I posted the clinical trial or if I posted. Did anybody look at that? Was it the clinical trial that I posted? Let's see. That's the bottom one is definitely the. Oh, here we go. No. Okay, let me see if I can. I know where it is. Let me see if I can put the clinical trial in for you. Hold on one second. It's here. I thought I had it under UCSF. All right, I'll find it afterwards, Peter, and I'll send you the clinical trial. I know I've got it. I know I've
Great.
got it bookmarked. Let's see. Here it is. Okay, hold on a minute, and I'll put that in. This is a here's the clinical trial coming up.
Rick, I also posted a summary that I found on Inspire just now, talking about all the different PET scans that are available, including PYL.
Okay.
You know, some of them you shouldn't be having on. You shouldn't be on hormone therapy. Some of them are better for lower PSAs versus higher.
Well, who wrote it though? Who posted that on Inspire?
I don't see any acclamation for the actual study. I'll see if I can find out who's posted it.
Yeah, I mean, again, you know, just be careful what you. I mean, Inspire's great, but you've just got to have trust in the person that posted it, and you've got to know where that information came from. I mean, you know, I really feel that Alan Edel is very, very credible. It may be Alan that posted it.
Yeah, so it is Alan Edel.
Is it? Okay. So yeah, so that would be a good that would definitely be a good report. But it's probably it might well be the same post that I referenced, because that post came off of his own blog site. That's further up. All right, let's Peter, anything else?
Can I just say one final thing, Rick, on this topic? Rick?
Yeah, yes, go ahead.
Oh, okay, I'm sorry. So the guys in the nuclear medicine department at Roswell Park have told me a number of times that the gallium PSMA scans will be the standard of care in the future, and very soon.
Right.
And the argument for them is that they will detect lesions that are not just bone lesions. I don't know if you or someone else just said that, but to me, that's a big advantage, to be able to detect soft tissue lesions as well, where the sodium fluoride 18 scan that I'm receiving now and the conventional scans only detect bone lesions. But I wonder, in discussing these things with these guys and my oncologists, it's not really clear how important the greater sensitivity that some of these scans provide is when, for someone whose tumor burden at the moment, like me, is very low and I have a very low PSA. So, for whatever it's worth, they're telling me not to worry about it and just go with the, the F18 sodium fluoride and think about replacing that in the future when things get worse.
Well, Bill, I mean, I think that they are very important. I think they're important to people like Peter, for example, or Len, who, now that we know that there is certain more aggressive treatment that seems to be effective as soon as you know that you have clear bone metastasis or soft tissue metastasis, then the sooner you know and can recognize that, the better you are. I mean, it may not be as important for a man that's got a higher tumor burden where there's a lot of metastasis, and really what we're more interested in is the comparison between 0.1 in time and 0.2 in time to see how your treatment is doing. But I think for men who are unsure where their disease is going, these more sensitive scans are critically important.
No, I said, I'm passing it on for whatever it's worth. The fact is, I already know without a doubt that I'm metastatic.
Right.
And that when there was a question whether or not I was metastatic, these were much more important questions, and and I insisted on the more sensitive scan.
Right. Right.
But for anyone that's not, who's still not certain that they're metastatic, yes, you're absolutely right.
Right. And ask them when you if you happen to run across them in the corridor or something like that, ask them what they know about this 18F DCSF PYL scan.
I plan to. Yeah.
Yeah.
Yeah. That's not one I've heard of before.
Yeah. Okay. Anybody else want to talk about this topic before we leave? Okay. Let's move on to John Appler, who had his seeds implanted yesterday, I believe.
High dosage brachytherapy at UCSF.
High dosage. Sorry, high dosage.
Pardon me?
Forgive me.
I'm sorry, high dosage.
Yeah, I was thinking it was low dosage. Okay, so you had your high dosage yesterday. Good.
Yeah, it just went remarkably smooth. I mean, virtually no pain until the very end, removing the catheter. A little bit of pain there, but a little bit of, pink in my urine a day, and that's really it. I'm just amazed. And I think just talking to you and Peter and other guys here that little bit of pink in your urine is not unusual.
Right.
Right.
Good. Okay. Yeah. So I remember talking to Peter about making sure they don't have to put it back in and be careful when they remove it, and all those lessons from these calls, came into play. But, I thank you again for recommending UCSF. I was very happy and amazed how smoothly the whole operation went.
Great.
Smoothly and pain-free.
So this was with Joe Shu?
It was.
Okay. Okay. We know many men who have been treated by Joe Shu, although I have actually never met him. But I do know several men that have had him, and they've all been very pleased dealing with him.
Yeah, I'd highly recommend it. In fact, if you do some searches on the web, you'll find he's authored a lot of the procedures for this operation in detail.
Right.
And he does appear to be, pretty well known for it. So thanks again for recommending him.
Right. How long ago did you finish your IMRT?
I finished it on Wednesday and had the brachytherapy the following Monday.
Wow. So it may well be different with HDR. I know that with the low dose brachytherapy, the seeds, which is what I had, they like to wait a little bit of time between the two procedures, but it could well be that with the high dose, it's very different. So I don't know.
Yeah, I remember that. It might have been because I was anxious to get back to Hawaii, so maybe they rushed along a little bit. I don't know.
That could be too. That could be too. I hope you're going to air freight some lays to all these docs at UCSF.
Yeah, you're right. I absolutely should. Yeah, and just by the way, does that pink in the urine, should it clear up in a couple of days?
Right.
Is that typically what happens? Good. Okay.
Yeah, it should do. Yeah, I mean, Peter, you'd agree, right? I mean,
yes. I never had HDR though.
Right.
But yes, urine does clear up pretty fast. Drink a lot of water.
Right. I mean, the fact.
Will do.
That the fact is that they are piercing the prostate gland, and it results in bleeding, and that blood empties into the urethra, and out of the urethra, it's you piss it out. So if you're not having any pain and there's not a lot of bright red blood, I think you'll find that it'll just resolve itself. I don't think it's anything that you need to worry yourself too much about. Again, I'm not a doc, and you should ask your docs, but if it were me, I know I wouldn't be too concerned about it. So
Yeah, that's good to hear. There's absolutely no pain whatsoever.
Good. And
Just a point of
yes,
just a point of clarification. Is the HDR, is that the one with the rods
that's
as
correct.
opposed to the seeds? Okay.
That's correct. And
So it's very, very similar to a biopsy.
yeah.
Yeah, you know, it's even less than.
Say again, John?
Oh, I was just saying it seems even less intrusive, less painful than that because they use very narrow needles kind of thing, and it leaves very little wound afterwards, and next day you're fine. As Rick found it out as well. I think Rick, you said you went rowing the next day, I believe.
Yeah, I had but I had low dose, so they put in seeds for me, so the seeds stayed there. But yeah, I was rowing the next day. I probably would have rowed the same day, but I had quite a long drive to get to and from the procedure. So, but John, I think that this whole experience, thank goodness, has been pretty positive for you. And now the question is just persevering with the ADT, and that can be the most difficult thing. The treatments, the radiation treatments are not that hard, but there are several men I've known over the years who have been diagnosed with high-risk cancer like you were and like I was, and they have not persevered through the ADT for many different reasons. And some of those men have found the disease have come back. I'm not saying that if you persevere, the disease is guaranteed not to come back. But what I am saying is, in my view, you've got to do enough ADT to allow the treatment to have an effect.
Yeah, I sure will appreciate that. Dr. Roach took me off of the bicalutamide.
Right.
I'm still on the loop on 3-month shots.
Right. And how did Mac indicate how long he wants to keep you on that?
Yeah, he did say 2 years, and I said, Dr. Roach, I have a 0.7 PSA already. He said, doesn't matter. You have a very strong cancer. We've got to do all we can to knock it out.
Right. And I think he's looking to try and get that PSA down to less than 0.1, which may well happen over time. So, 6 months from now, I think that there's a good argument, even with Mac, that after you've done 18 months, you can argue with him, do I have to keep going? Because there's a good study, which he knows well, that says that 18 months is as good as 36 months. That wasn't available when he gave me at the time 28 months. If you can get through 18 months on the ADT and you can persevere with that and do whatever you've got to do, I think you're giving yourself the best possible shot.
Yeah, appreciate that. That's exactly the course I'll follow.
John? What does he have? What do they have you on for follow up? Monthly PSAs, twice every other month, phone consultations. What's your follow up schedule?
They told me to wait about 3 months before I did the PSA test. They thought it might be kind of skeltered off, after all this radiation. But then I'm on monthly blood tests, and then the PSA monthly to the extent I can do that.
Okay. Did Diane have a question? I heard her voice in the background.
Oh no, she's just we're walking down Union Street here. She's listening.
Okay. All right, because we don't want to cut her out, I mean, if she's got questions, they're very valid.
Rick says, do you have any questions, honey?
No.
She's okay.
Okay. When are you guys returning to Paradise?
We're flying back on Thursday, and can't wait. To tell you the truth, we're just accustomed to warm weather, and we don't have it here, so we're looking to get back home.
Well, I understand that. I mean, we've now, it's been about 10 degrees above average this week here. So, you know, I think it was well up in the 90s today, which was, I mean, not, but it was very comfortable. And I'm thinking to myself, you know, how lucky I am to be in this part of the world at this time of year. 88, it's supposedly 88 right now. I think the high was 89. So I'm enjoying it.
I'd take that right now, Rick.
I bet you would. I bet you would. I mean, it's a little cooler at night, but it's not that cold. And it's cold in the morning, though. I gotta wear a fleece, and I gotta wear long trousers in the morning until it warms up. But you know, once it warms up, this is why people live down here. So I'll talk to you, John, after you get back to Hawaii. I'll give you a call and we'll chat.
Okay. Will do. Thanks again for everybody's help. I appreciate it. And thank you too, Bill's on the phone, for great consultation about genetic testing.
Okay.
You're welcome.
So let's move on to Paul Frieda. Are you still with us, Paul? Yes, you're back.
I sure am. I dropped out at one point. Something happened to my internet, but yeah, I'm still here. All I have tonight is that I'm celebrating my second year now on successful with Lupron. I just had my blood test, and I'm still undetectable. And it's my understanding that I'm sort of at the median point of getting 2 years out of it with a Gleason 8. Mm-hmm. And I'm just wondering if I'm on track with that, or is there no way to tell how much more time I'm going to get?
And I don't know that there is. I kind of like to defer that one to. I mean, you started your Lupron when your disease came back, and you finally decided that you would consider radiation. Wasn't that right?
Well, I considered radiation, and I elected to pass. And the reason I did is, let's see. The main reason was Dr. Walsh's book said that if you're above 0.2 after your prostatectomy, you're probably metastatic, and so it's pointless to do radiation. But that wasn't my only consideration. I did consider other things and other opinions from other doctors and whatnot, and given the risks of the kind of quality of life reduction you can get with radiation, I decided not to do that. I'm still not sure I made the right decision because, as you were telling me, Rick, that I might have had a chance for a cure at that point, and but I didn't go for it, and you know, I may regret that depending on how things move in the future. But I didn't do radiation, and I started on Lupron about 2 years ago. I think it's just about 2 years ago this month. And my blood test came back just this week showing I'm still, you know, undetectable. So that's good news, but I have to be aware that, you know, the Lupron isn't going to work forever. And I'm just wondering if there's any way to predict how long I'm going to get out of it. I think, did you get like 5 years or something, Rick, or what did you get out of it?
Well, I'm in a different boat, so I'm in a very different boat to what you were, because my disease never came back. I was treated with neoadjuvant and adjuvant ADT. But I want to say a couple of things about that, and then I also would like to hear what Peter's got to say, because this is probably more in his ballpark than it is in mine. What I'd like to say to you is that we're seeing more and more people with recurrent and advanced disease being treated with radiation, even when they're metastatic. And I think that whatever Walsh says in his book, number one, Walsh is a urologist. He's not a GU medical oncologist, and you have to take that into consideration. Number two, that book was written a long time ago. And number three, we see men now being treated with radiation even when they have metastatic disease. And probably the best example of that is Ken Anderson, who in fact not only did they debulk his tumor because he was diagnosed metastatic, so he was in a position where his tumor could be debulked, as was, for example, Dr. Steve and others. But Ken is the first guy I know who, with metastatic disease, they actually gave him, or he's still doing radiation of the whole pelvic girdle. So, to me, it's not too late to radiate your whole pelvic girdle if you were of the opinion that you wanted to do that, and that's what many of us on the call have done. And I don't think that we've got significant lifestyle deterioration from having the pelvic girdle scan. So it's not too late still to consider radiation. If it were me, again, this isn't medical advice. I know I would be getting pelvic girdle radiation because I think it's something that is really important to confine the disease. And we don't know in your case where your disease has gone. So I don't think we should even be talking about how long would Lupron last. I mean, most men in your position, depending on how they were tolerating the androgen deprivation therapy, would be thinking, well, can we take a holiday? And with that cue, I'm going to pass it on over to Peter.
Well, my holiday is coming to an end. Just in time for the holidays, probably.
Right.
No, I don't know. I've been off now for just about a year, and and I'm going the wrong direction. I mean, I made it about a year. It's been wonderful having some testosterone back and feeling energetic again and doing okay. But I know that I'm going to be a candidate. Now, when I went off Lupron and bicalutamide, I was not resistant to them. It was still working for me. It brought me down to undetectable, and I could manage it. I was doing okay. I mean, I wasn't happy with the side effects, but it wasn't terrible. And that's going to be one of my questions for my doctor next month is, do I go back on Lupron because it still worked for me, or do I go to Zytiga or Xtandi? And so if this is still working for you, I would just stay on it. That would be my guess. Unless you're really having a hard time with it, I would just stay with it if it's keeping you at an undetectable level. Unless you're really fighting the side effects.
Peter, what would you say to Paul about pelvic girdle radiation?
Well, I did that. I did that in my IMRT session, and that'll. Let's see, 16. 16. So that'll be a year. It'll be 2 years in March when with my IMRT. It'll come up to 2 years in March. So it's been over a year and a half. And again, until I get a scan after the first of the year, I won't really know what's going on. But I think it helped. It gave me an undetectable situation for quite a while. So I'm glad I did it.
Say, Rick, Bill Whittemore. Oh, sorry.
Go ahead, Bill.
I wanted to just say, so this is a bit of a yesteryear reference point, but after my radical prostatectomy in January of 2000, I had the pelvic girdle radiation, because even if it is out of I had a 2.0 PSA a couple months after my operation, and their idea was, even if it is out of the prostate fossa or bed, it may still be within the range of the, as you put it, the pelvic girdle. And so I made the decision to go ahead with it. I then went on Lupron. Well, first I went for several years without any treatment whatsoever. And then I went on Lupron about 8 years after the operation. I wasn't undetectable, but I had under a 1.0 PSA all through that period.
Mm-hmm.
And then I went on Lupron, and it was 4 more years before I started taking nilutamide, and I was still good until I had metastatic, bone presence in 2013. So I went for 10 to 12 years, just FYI, with a very low PSA and Lupron, and for many years before that without any treatment at all. So what are the possibilities of your longevity on Lupron? Who knows, but I thought I'd give you that anecdotal information.
What's your Gleason score?
6.
Yeah, so you're a 6. I'm an 8.
Yeah.
And I'm a 9. I'm a 9, and I had it had gone to my seminal vesicles, so I had some serious issues.
I had seminal vesicle involvement myself.
No, I did not. After my post prostatectomy pathology was pretty good. There was nothing on the borderline, and nothing in the lymph nodes, and so it looked good. But the PSA was not. There was one thing unusual about me. I had let's see how many years. I had like 13 years of a PSA sitting at 12 because I had a very large prostate, and so it was I had BPH, and and so I'm one of my second thoughts about the choosing not to do the radiation was that there might have been 0.2 because I had a lot of benign cells in there that were producing PSA, and that's why it was high. And so if I had gone ahead with the radiation, whatever residual cancer that was in there could have got destroyed. But I didn't consider that. In fact, I don't think I knew that benign cells can produce PSA. So, but like I said, I had a huge prostate. When I asked the doctor after the operation how big it was, he held up his fist and opened it up a little bit and said, "Yeah, this is how big your prostate was." It's like five times the size.
How many cc's was it, Paul?
I think it was like 160, something like that.
Yeah, which is big. I mean the largest that I've heard of are in that 150, 160 range. I know a couple of people that had PSAs that large, and that is huge. But for men that have a PSA of that size, the normal a normal PSA could be as much as 16, just because we figure that your PSA should be about 10% of your prostate size. That's why 40 is an average prostate, and that's why the norm is about 4.
4, right? Yeah. So yeah, I was I was way up there. In fact, the only reason I found out that I had the cancer was that I ended up with blood in my urine.
Right.
And then when I went, he stuck his finger up there, and his face turned white.
Right.
So.
Right. So I want to go back to Bill with one question. Bill Whittemore.
Yes.
Was that 3+3? Was that the post prostatectomy Gleason, or was that your pre-prostatectomy Gleason?
Yeah, well, I think it was the pre, and I'm sorry to say I don't know what the post is. I should, but I don't.
Yeah, okay. So, probably my guess is that your post prostatectomy Gleason had a 4 in it somewhere along the line.
Yeah, but I think it's possible for people to go a long way on Lupron, and
I do, yeah.
or before things start to get very, very serious.
Right.
Depends on the guy, but there are good stories too, and I hope yours is one of them. It sounds like you're doing very well.
So I want to leave enough time here. I see that Tom Van Zandt is on the call, and we haven't heard from him for ages. And I know Professor Bill wants to talk to us. So what I'd suggest is, unless there's anything else, Paul, that you'd like to focus on, or I think we've given you quite a few things to chew over here. One thing that I would suggest is that a discussion with a good GU med-onc might be in hand to decide how you move forward.
All right. Well, I'm going to see him Thursday.
Okay. What's your guy's name? I forget.
Abraham Schwartzberg.
That's right. I knew it was Abraham. I couldn't remember. And is he a GU med-onc or is he a general practitioner?
Well, if a GU med-onc only treats prostate cancer, then he's not. But because I know he's got other kinds of cancer patients in there. But his shingle advertises he's a GU med-onc.
Okay. Okay. Now a GU med-onc would treat all genitourinary cancers, which would include testicular, kidney, bladder.
Well, he's got a hematology guy in there.
Okay.
I'm not sure exactly what that means, but that's a blood expert. But
usually, if they're hematologists, then they're not solely GU med-oncs. But I really want to encourage you to be sure you have a good GU med-onc on board, because there's so much going on. There's so much going on in this field that.
Yeah, I know. When I searched Southern Florida, he was the only one I could come up with.
Well, it may be that what you've got to do is get on board like some of the other guys have done. Get on board with a GU med-onc somewhere local, somewhere not too far away, who would work with a local guy.
Well, they apparently have a couple in Tampa, but one of the reviews I've read were quite mixed about their happiness with them. And I don't know, maybe Atlanta has some good GU med-oncs. I'm not sure. I don't know.
Not really.
I guess in the if worse comes to worse, I could just bite the bullet and fly to New York. So. No,
I would say, look, Atlanta does have one guy, Bradley Carthon, but I think he's okay. He wouldn't be my first choice. Tampa does have some good. Moffett, they have a couple of good guys, but I would probably go to Anderson in Houston. That would be which isn't that far from where you are, and I would see one of the guys at Anderson, and we have some good names at Anderson, but I think you need to get them on your team.
Yeah, I may have to do that. That's right. Right.
They're going to be covered by. If they're not covered by your insurance now, you can change to a plan that will cover them, and it won't be that much more expensive.
Well, I've got my supplemental is Mutual of Omaha. They seem to cover everything.
Okay.
And so I would hope I'm covered there. But if I'm going to go all the way to Houston, I might as well go to New York. I don't know how much farther that is, really.
Well, but you're going to get as good treatment in Houston as you are in New York.
Oh, okay.
Right. Why do you want to go to New York?
Well, my prostatectomy surgeon is there, and so I'm in the system, and I can get good recommendations, from them and whatnot. And also my family is up in New York.
Okay.
So.
Okay, but let me ask you, Paul, you think you're going to get better recommendations than you would on this call?
I guess I doubt it because I don't know anybody. I don't have anybody in the inside. I would first go to my surgeon and see who he recommended. But no, but of course on this call, we I've got 20 different guys that that are contributing
Here's the
to
problem. You go to Memorial Sloan Kettering and speak to your surgeon, and the question is, who's he going to get you in to see? Howard Scher, probably not, because he can't see you. Michael Morris, possibly. Susan Slovin, I would stay away from her. I'd steer clear of her with a barge pole. For a whole bunch of reasons. Dana Radcliffe, absolutely excellent. I definitely would recommend Dana Radcliffe, as would many others on this call. There are a couple of others. I mean, there's Dan, I forget his name, Danila, who Len saw and wasn't thrilled with. So, we can give you a rundown on most of the Memorial Sloan Kettering. So, the alternative is go to somewhere like Duke, which is closer, and we can give you good names there. Go to somewhere like MD Anderson, which is closer for you. We can give you good names there. If you particularly want to go to New York because you've got social reasons to be there, fine. I would say to you, go make an appointment with Dana Radcliffe because you'll like her. She's very much on the ball. She's doing some cutting edge research right now. There's a whole bunch of reasons.
Do I have to see them in person? Will they see you with a video call?
I think
they won't do that.
I think they will, or they'll speak to you, but you've got to go there for the first time. You've got to make an appointment in person.
Okay, after first in person, they might be willing to talk to you.
Well, I know the doctor at Anderson would.
Okay.
So
all right.
There's got to be some good GU med oncs in Florida. It's hard to believe that.
Well, that's what I thought. There's so many old people here, and the statistics of having prostate cancer, are proportional to age. And I just expected to be there to be a flood. And I literally, now maybe my search was wrong. Maybe there's 5 guys and I haven't find them. Maybe I'll try another search and ask a couple of doctors about it.
Okay.
But
I'm going to cut this conversation because we've got.
I've taken enough time. Go ahead, move on to other guys.
And I want to make sure we touch base with Bill and we touch base with Tom Van Zandt. So, Bill.
All right. Thank you very much for your time. I appreciate it.
Pleasure. Bill, you're up. Professor Bill.
Okay. So, I think that I told you guys earlier that beginning about 6 months ago, my PSA began to rise, and it continued to rise with repeated measurements over that period of time until about 3 weeks ago, and which meant that the olaparib was losing its effectiveness. And this is not unexpected. The mutation that it's interacting with is one that can revert back to wild type fairly easily. And I've talked to Johan de Bono in England about this, who just published a paper about how frequently this occurs. But then about 3 weeks ago, it went back down again by a significant amount. So it's still very low. It's relatively low, I guess I should say. It had climbed from, it bottomed out at about, I think, 0.3, and it climbed up to 2.2. And this last reading, it went back down to 2. So I had been making all sorts of plans about, how to pursue the next line of treatment. And now I'm sort of putting them on hold, at least until I get another PSA reading when I get back from Vermont in a couple of weeks. But, I don't know what meaning my oncologists, and I don't know what to attribute it to. I don't think it's it's beyond the range of error of the measurements. And the two possible explanations I can think of are, one, my younger daughter has in the last couple of months met the Pope twice and maybe she slipped him a message or something, but I don't think. And I think that the more likely explanation is that about 3 weeks before this last PSA reading, I began to take metformin. And I had been taking it earlier, but then stopped because I ran into problems with nausea. And then you guys, I think it was Jake, encouraged me to start it again and take it with food, which I had stupidly not been doing, and now I am. And so I think that it's a good possibility that it's the metformin. So knocked it back down somewhat. So I don't have any real questions. I just thought that I would report on.
Well, a couple of things. One is that, and there's research, and I'll see if I can find it for you. And I just saw a reference to it, but there is good research that metformin makes enzalutamide much more effective.
Okay.
And so it's kind of like a turbocharge. And I'll find, I know I've got it bookmarked. I'll find it for you and send it to you afterwards. And I also recall that Charles Mack, also just made a post on Advanced Prostate Cancer, the Australian site, about metformin and enzalutamide. I'll see if I can find that. I saw it this week. Don't think I bookmarked that because I've got some other stuff on metformin and enzalutamide. But I remember this, it was from about a year to 2 years ago, that there was significant impact of metformin on the performance of enzalutamide. So it may well be that the metformin is improving the enzalutamide because you're still on enzalutamide, correct?
Yeah, that's correct. Yeah.
Right. I'll send it to you.
It's interesting. It's hard to imagine, knowing how they both work, how that would occur. But I'd be very interested to learn more.
Okay. So I'll send you the research. You have to explain to us how it works. Is that a deal?
That's a deal.
Okay. It may well be a really good plan. Just to stamp out, I owe a note to Chuck Ryan. I'm sorry, it slipped my mind. I will write to Chuck Ryan on your behalf to introduce you to Chuck, because as you know, there is a study that they are about to start for men who have failed, who are BRCA positive and have failed the PARP inhibitors. And so he had mentioned to me that he would like to talk to you and he'd be interested in maybe at least including you in the sample, if not in the trial. But I'll make that connection, Bill. I'm sorry, I forgot to do it.
That's okay. Not a problem. If I don't hear from you, Rick, I'll remind you. Because I think, it's nice to take a couple of weeks and not think about these things after I got that result. But the fact is, I do need to begin to think of them again. And I should also say that, Johann de Bono indicated, somewhat to my surprise, that he thought that there was a possibility that switching to a more potent one of the new generation PARP inhibitors might work better, despite the fact that the olaparib is losing effectiveness. So I'd really like to speak with him. I'll remind you.
Okay, and then you looked at. I don't know if it was included. I think it was included in the abstracts, but they didn't actually put up the poster. But the abstract number 16 by David Quigley, analysis of circulating cell-free DNA identifies multiclonal heterogeneity of BRCA2 reversion mutations associated with resistance to PARP inhibitors. Did you look at that study, Bill?
Yes, I did, and I am planning on having a CTC analysis.
Okay.
I'll have a blood draw for that when I get back to
Okay.
Buffalo.
And, you know, Quigley's supposed to reach out to you, but you can reach out to Quigley as well.
Yeah, okay.
And
I think, you know, this will be critical to see whether or not the mutation has reverted.
right,
Because if it has, then that, you know, absolutely rules out any PARP inhibitor in the future.
right,
It essentially means that I'm wild type for the BRCA mutation.
right.
I shouldn't say it absolutely rules it out. I could have other mutations in the same pathway, but in any case, it's important information.
I think I'm trying to remember who they said was doing that study. I think it was Felix Feng and Chuck Ryan. I think those were the two docs they said were doing it.
I have to go back and look at your emails. Yeah.
But anyway, and then Quigley is going to be the data analysis guy on that study as well. So he's a PhD. He's a researcher like yourself. So, but I'll make it happen. I put a note. I've got a note here. I made a note, and I'll take care of it tomorrow morning.
Great. Okay. Thanks.
Anybody want to talk to Bill about what's going on?
Rick, I had one post on metformin on Facebook, and I posted to the link. It's about a year old, but that might be a good starting point for Professor Bill.
Was that I see you put it in the window? Is that about enzalutamide and metformin? No, it's about abiraterone and enzalutamide. Huh? Okay.
Yes.
Okay, great. Thanks. There you go. There's a start for you. And
it refers to the actual study. You know, this is one of those summaries that I can understand, but it refers to the actual study. So, and I know Bill can find that.
Great.
Terrific. Thanks. I appreciate it.
Great.
Okay, you're welcome.
So, what was I just going to say to you? Oh, Bill, there were a couple of these abstracts that you thought were relevant to the guys on the call. One was that possibly there's some value to retreating with Provenge, isn't that right?
Yeah, that caught my attention. I have had Provenge treatment, and I've always wondered whether or not a booster shot or it's not a shot, but a booster course of therapy might be useful. It just seems intuitively that it would. You know, it's a vaccine type of therapy, and according to the abstract, there was a study performed that addressed that question, and the answer is that it does. It is worthwhile to go through another round of it. But of course, there are no details, and it's not something that's going to be available, or you know, I don't think if I went to my insurance company and asked them to pay for another round, I doubt very much that they would agree to pay for it based on this abstract. But I'm looking forward to the paper, you know, the study being published, so that you know, I can then take it to them.
Yeah, that, guys, is abstract number 2. I'm afraid the explanation was a little bit above my pay grade, and the guy had a very thick accent, so I didn't get a lot out of it. But it's abstract number 2 on the list if you want to look at it yourselves. The one of the papers that really struck me, and it's still very early, is a novel agent that comes out of the space program called RRX-001.
Yeah.
And what they found was in lung cancer, and they're now testing it for prostate cancer, that if you have small cell or neuroendocrine disease or one of these morph types of diseases, like, say, Jim Harrington has, that this agent seems to make carboplatin a lot more effective. And I went up to the presenter afterwards and asked her if this agent was available in any way, shape, or form off-label, and she told me it wasn't as yet. So this isn't one of those situations where the drug's already been approved for a different disease. It has not. But we should keep our eye open and try and see what happens. Try and watch out and see if it does get approved. And then I'm just looking here. PSM. There was a presentation after that by this guy Henry Van Braaklen on PSMA PET imaging. So for those of you like Peter and Len, you might want to look at abstract number 7 as well, because that's pertinent to what we've talked about today. I want to touch base with Tom Van Zandt. Tom, are you there? You're grayed out. Are you with us? Yes, you're with us.
I'm sorry. Can you hear me? Yeah.
I'm glad you're still here. I was almost getting ready to send a note to see what was up with you. We haven't heard from you for ages. You don't love us anymore?
Well, I'm doing all right, but I called in tonight because I'm getting really sick of Lupron, but I have to stay on it.
Mm-hmm.
It's having a lot of effects on my muscles, where I'm getting weaker and weaker in the legs and arms. You know? I'm just getting sick of it. I've been on it 5 years now. I'm getting really tired of it.
Mm-hmm. Mm-hmm.
But I don't think I have any choice but to keep taking it.
Do you still have that? Are you still using the Russian guy at?
Yes. At Fox Chase. In fact, I'm going to see him in about 2 weeks.
Okay. And is your PSA still undetectable?
Yeah, it's below 0. Yeah.
Okay. So you're a guy you're a bit like Paul Frieda.
What's your Gleason score?
What was that?
What's
your Gleason score?
What was your original Gleason?
Originally they said it was a 7, and then I went down to Johns Hopkins, and he read it more like an 8.
7 or 8. You got 5 years. You got 5 years out of it. That's amazing.
Yeah.
But you've had have you had radiation or not? I can't remember.
No. At New York, a couple places they told me that basically the horse was out of the barn. It's into your lymph nodes, and radiation isn't going to do you any good.
Yeah, well, as you heard the conversation, I don't know, were you on when we had this conversation a little earlier, Tom?
Yeah, I heard you talking about it, but I didn't know if that was for someone who had it in the lymph nodes.
Well, yes. I mean, the thinking now. I mean, I had the discussion with Ken Anderson, who's seeing Paul Korn at MD Anderson is his lead doc, and Paul Korn, and I said, double check with Korn that not only is your doc planning to radiate your prostate gland with metastasized disease, but he's also thinking of doing the pelvic girdle. And Paul Korn said absolutely. So even with guys that have more advanced disease, they think now there is value to doing this. But that's exactly what I said to Paul Frieda earlier on. But Paul Frieda and Tom Van Zandt, you guys are in similar situations here.
I did ask about that the last time I was at Fox Chase, which was about 3 months ago, and it was a physician's assistant, and the guy said, I just don't understand why don't either remove my prostate or radiate it. And I said, I understand it's metastasized, but to my mind, you have this huge cancer generator sitting in there unmolested.
Right. And the thinking now, Tom, unlike several years ago, is maybe it should be debunked. So I think that when you see Gainesman in a couple of weeks, one of the questions on your list would be, what are your thoughts on some additional radiation? I mean, you don't have a prostate at this point in time, right? It was removed, wasn't it?
No, it's unmolested.
Okay. So yeah, I would definitely talk to him about debulking. because there's a complete different view on debulking to what there was 5 years ago.
I never heard that term, debulking.
Debulking, yeah. B-U-L-K, debulking. I mean, the idea is that you take out, is exactly what you say, you take out the generator.
With radiation.
Well, there are some people that do it with surgery. They originally, they talked to Ken Anderson about surgery, and I said to him, you know, don't even let them cut you. Do it with radiation, because today you can do it with SBRT, stereotactic body radiation. You can have 5 or 6 shots. That's all you need. And, you know, that's what Dr. Steve had. And so you can do the debulking with radiation. And then the question is, well, what about pelvic girdle radiation? And like I say, we're seeing that happening as well.
Okay.
So, you know, I think both those questions, and you're a little different to Paul Frieder in that Paul Frieder did have prostate removed originally. Now, as far as the side effects from the hormone therapy, are you exercising? I know it's tough sometimes, but are you still?
No, I do exercise. I have a weight set downstairs, and I also walk at least a mile a day, if not 2.
Okay, great. Okay.
And I jog sometimes if I can.
Yeah. Well, that's great. So, you know, you're doing the right things, and it does make a difference. But yeah, it builds up over time. And you know, the other discussion to have with him is, should you, is there any possibility to stop, take a vacation until you feel a little better? I mean, it's going to mean that your prostate, that your PSA is going to come back. And the studies seem to say that for men like you, it's not the best thing to do. But if you're feeling really rotten and it's a quality of life issue, it's worth the discussion with your doctor.
Yeah, I'll have to have a talk with him when I get there.
So, you know, those are 2 things. 1, the holiday, and 2, what about debulking?
I have asked about holidays before, and they said, no, it's not for you.
Right, which is probably true. But, you know, there comes a point in time where the quality of life becomes a significant factor. Anybody else want to talk to Tom about?
I'm curious. Yeah, it's Larry Fisher. Tom, have you ever done or thought about Xtandi or enzalutamide or abiraterone?
I'm on that. I'm on Lupron plus Zytiga.
Zytiga, just Zytiga, not and how long have you been on the Zytiga?
I guess about eight months or so. I don't know.
Yeah. What was the reason that they decided to add Zytiga? Was your PSA started to go up again, or just?
Well, I was on Lupron and Cassidex, and the Cassidex was no longer controlling the PSA.
Right.
So I went on to Zytiga, and that had a very good effect. It knocked the PSA right down, and it's been keeping it down.
Yeah, it's exactly where I'm at. I'm just, I was on the Cassidex withdrawal, which is now failing, and it's just a question of enzalutamide or abiraterone and possible trial with some other PARC inhibitor or some other option. So I'm right where you have just, been, and I'm very interested in this idea of debulking the primary and pelvic girdle radiation, even though I have currently a bone met to the pelvic. It still seems to possibly make sense. That's just my way of thinking. I don't know if other guys would agree with that. To discuss it at least.
They did the study at Memorial Sloan Kettering, but the study was A, relatively small number of people, of patients, and B, they stopped it after, I don't know if they stopped it, but they reported after like 20 months, which really wasn't a long enough period. And they did find that there was a positive effect, and that was with surgery, that was with radical prostatectomy. For people that had been diagnosed with metastasized cancer. My recommendation would not be to do a radical prostatectomy, but to do stereotactic body radiation because it's less invasive, CyberKnife or something similar to that.
Wow.
Now, Rick, how much radiation exposure do you get from that, and what are the risks or side effects from the SBRT?
Well, I mean, it's a significant number of grays. I don't know how many, probably 45 grays. I mean, it's a lot of radiation that you're taking. What are the side effects? Well, the side effects, depending on the location and what they're shooting, I mean, there can be urinary and rectal side effects. That's the issue that concerns people like Paul Frieda. But, you know, I think the incidence of those side effects has not been reported to me by men who have had it as being significant. I mean, it's certainly the guys that I know who had it, like Steve and Ken Anderson, to date haven't reported any side effects. I had side effects from my radiation, but I also had a weak bowel going in, and I also had a lot of radiation. But, you know, if doing this can extend your treatment life by a couple of years, 2 or 3 years, maybe it's not such a bad thing. But this is what you have to discuss with your doc.
So, Tom, this is Bill Burhans. As far as the weakness is concerned, I've been on ADT now for going on 5 years. Not quite there yet, and I've been on enzalutamide for the last couple of years, in addition to olaparib. And I've periodically go back to the medicine clinic with a physical therapist, or I'm sent back there. Usually after I've been hospitalized and my musculature just collapses. And they've been really helpful at providing me with, with exercises that are really efficient and effective at building up my strength again. So I'm also, walking as far as I can every day. And, so this would be in addition to that. So I don't know. It might be something to think about. It would have to be, ideally, it would be physical therapists who know about the specific issues of prostate cancer patients and the effects of ADT.
Right. Thanks. I mean, I think that that's another question. I suggest that's another question you add to your list for Gainersman. If they may have some exercise physiotherapists that are sensitized to androgen deprivation therapy at Fox Chase, because more and more this is becoming popular. I mean, the program that we started at UCSF, we wanted to see at all of the hospitals, and it's been incredibly good. So much so that I'll refer you to abstract number 22, which reports on a study where they put men with metastasized cancer on a web-based lifestyle program that included diet and exercise. And they reported that the men who had the support did a little better than the men who didn't have the support. I mean, I have to say they spent an awful lot of money to come to that conclusion, because we knew that beforehand. But it was enough with 70 that they're now going to extend it to 250 and waste some more money. These men, by the way, were all wearing Fitbits, and they all loved the fact that they were wearing the Fitbits, and Fitbit was supporting this study. But my point is that 10 years ago, nobody was talking about this stuff. We were struggling. I mean, I was one of the really early innovators with one of the people on this study. And, that's sort of all been forgotten now. But we wanted to innovate a program like we have at UCSF with exercise support at all of the major NCI and NCCN hospitals, and we've been unable to do it because I can't get the funding. I wish I could get the funding. I wish I could get Fitbit to back the program that we innovated. So it may well be, I only tell you that because it may well be that at this point, Fox Chase is involved with, there's a big Movember study, and Fox Chase might be part of that. There may be some studies going on at Fox Chase, Tom, that would be appropriate for you. So make sure you put that on your list for Gainersman.
Writing it down right now. Okay, thanks.
Okay, so that's three items, and don't be a stranger. Come back and tell us what Gainersman said to you.
Okay.
Okay.
All righty, thanks.
Okay. So we're running a little late. We're about 10 minutes over, so we should call it a day. But anyway, guys, this has been a good session, and I hope I've encouraged you. By the way, the study, that last one, that 22, is really easy to read. You don't have to be at Professor Bill's level to understand that abstract. The title is a randomized controlled trial of a web-based lifestyle intervention versus a control group for men with prostate cancer. They had a metastasized group and a lesser group. So that one might be worth reading for some of you. Okay. Next Monday we will be back. I do want to tell you, I'm really excited. We're almost certainly going to have a female breast cancer call starting next month. Not exactly sure who it's going to be pitched at, what type of breast cancer. The two moderators are still thinking about it. We also have the call in England starting in January. But for any of you that know people with breast cancer, men or women in your life, friends, family, just let them know that Answer Cancer is going to be holding support calls for them. We have a male breast cancer call that's going to be once a month, and we have probably 2 female breast cancer calls. So spread the word. And if you need more information, just send me an email, and I will. I'll get right back to you on that. It's exciting.
Rick, before we go, would you mind telling me again what the vitamin D is? It D25 hydroxy? Is that the one I need?
D3-hydroxy 25.
D3 hydroxy 25. Okay, thank you.
Yeah. And again, for all of you taking D, check your D3-hydroxy 25 levels at least once a year and make sure that you're taking a dosage that is in accordance with your actual level. Okay?
Yeah, good night, guys.
Okay. I'll say good night.
Thank you.
All right.
Thank you.
Good night, guys.
Good night.
Okay, thanks, Richard. Bye.
Best to everybody.